Hello everyone, my name is Austin Grimm and I am currently a clinical pharmacy specialist at Texas Children's Hospital. And today I will be presenting to you all an overview on pediatric acute myeloid leukemia. Before diving into the meat of this presentation, I have no potential conflicts of interest in relationship to this presentation to disclose. There are 4 learning objectives associated with this presentation. So by the end of this presentation, you will be able to define the pathophysiology and diagnosis of pediatric acute myeloid leukemia, or AML. Second, you will be able to summarize the recommended frontline therapy for pediatric AML. Third, you will be able to explain the mechanisms of action and toxicities associated with various chemotherapy agents that are all utilized within the treatment of pediatric AML. And then lastly, you will be able to design a frontline treatment plan for a pediatric patient presenting with a diagnosis of AML. There will be numerous abbreviations utilized throughout this presentation that I've listed on this slide for your reference. Please feel free to refer back to these abbreviations whenever they are referenced throughout this presentation. Before diving into the pathophysiology as well as the diagnostic criteria for pediatric AML, it's important to take a step back and understand the history of the disease state itself. Leukemia as a term was first introduced in the mid-1800s by Virchow. However, it was not until the beginning of the 20th century that the first description of myeloblast precursors formally occurred. Although originally referred to as acute non-lymphocytic leukemia, it wasn't until the mid-1970s when a standard comprehensive morphological classification schema known as the French, American, British, or FAB system was formally published for AML. The French, American, British classification system was the first attempt to describe the variability amongst different forms or types of AML. It specifically categorizes different forms of AML based on morphology as well as cytochemistry. You will see the different subtypes range from M0 to M7, and then the various names for those different subtypes just depending on the specific morphological features. Later in 2002, the World Health Organization, in collaboration with other large consortiums, developed their own classification system. The main goal of this new classification system was to not only incorporate morphologic differences amongst the different types of AML, but to also consider genetic information, immunophenotypic, pertinent information, biologic information, as well as clinical features that ultimately were clinically relevant to a specific diagnosis of AML and that specific entity. So you will see within this classification system that there are 6 different entities within the AML umbrella, specifically AML with recurrent genetic abnormalities, AML with myelodysplasia-related changes, therapy-related myeloid neoplasms, AML not otherwise specified, myeloid sarcoma, and then lastly, myeloid proliferations related to Down syndrome. Before we begin to discuss the clinical presentation as well as diagnostic criteria of pediatric AML, it's really important to understand what's going on at a cellular level that then leads to these symptoms at diagnosis and then ultimately the formal diagnosis made by the medical team. So in terms of pediatric AML, the pathophysiology really surrounds the increased production and proliferation of undifferentiated myeloid precursors. So what that means is that due to genetic mutations within that myeloid stem cell, your patient will end up producing a significant surplus or increase in these undifferentiated cells that really lack the ability to function as our typical differentiated myeloid cells would. So what that means is your patient's going to have a significant reduction in functional red blood cell, platelets, as well as granulocytes, as you see in this flow sheet or diagram. What this ultimately results in is ineffective erythropoiesis, as well as ultimate bone marrow failure. So that, at a cellular level, is truly driving the various symptoms that we'll begin to discuss next. For the epidemiology of pediatric AML, the incidence reported is about 8 cases per 1 million children, with those cases representing approximately 25% of all pediatric leukemia diagnoses. The bar chart on the right-hand side of this slide provides a visual representation of the age of patients at diagnosis compared to the rate of incidence. Essentially, this graph shows that pediatric AML is most frequently diagnosed in patients less than 2 years of age, with an initial peak in incidence at less than 1 year of age that declines, but then increases in patients between 10 to 14 years of age. With that being said, there's little variation amongst different ethnic groups. And then in terms of response rates, there's an initial complete response percentage or rate of 90%, although the 3-year event-free survival is only 45%, as well as the 3-year overall survival of only 65%. There are a variety of concomitant factors, prior therapies, as well as various concomitant disease states that have been correlated to a pediatric AML diagnosis. This slide provides a very brief overview of various components that have been studied in the literature that have been shown to be correlated to pediatric AML. To start us off, environmental factors, so petrochemicals, solvents, pesticides, ionizing radiation, have all been correlated to some degree to a pediatric AML diagnosis. Prior chemotherapy regimens, specifically alkylating agents, as well as topoisomerase II inhibitors. And then various hereditary conditions have been correlated to pediatric AML, specifically Fanconi anemia, congenital dyskeratosis, Diamond-Blackfan anemia, Schwann-Diamond syndrome, as well as Down syndrome. Interestingly, Down syndrome patients have been shown to be at a much higher risk of developing a myeloid malignancy versus non-Down syndrome patients. With that being said, though, they have been also found to have a much significantly higher event-free survival and overall survival, which is quite interesting and ultimately plays a role in their treatment that they receive versus non-Down syndrome patients. Now that we've discussed the pathophysiology of pediatric AML and discussed some of the various etiologies associated with the disease, let's go through and discuss how a typical pediatric AML patient would present at time of diagnosis. We'll discuss both laboratory abnormalities that then lend hand to the symptoms that are presented, again, at the time of diagnosis. So most of the laboratory abnormalities are seen on a complete blood count or CBC with differential, specifically anemias, thrombocytopenias, neutropenias, and then the presence of circulating leukemia cells, which are commonly denoted as blasts on CBCs. Lastly, coagulopathies are also frequently reported in this patient population. And all of these laboratory abnormalities are all associated with the development as well as growth of the disease process within the bone marrow itself and other parts of the body. As I alluded to earlier, the clinical symptoms that are associated at presentation can all be correlated back to these initial laboratory abnormalities. Specifically, fatigue and weakness, pallor, dyspnea on exertion are typically due to these anemias at baseline. Bleeding gums, petechiae, which are small round dots, either a brownish or reddish color, that note bleeding under the skin, as well as easy bruising, primarily due to thrombocytopenia that these patients present with. And then various neurological side effects or symptoms are present or may be present at diagnosis, so specifically headaches, vomiting, irritability, all thought to be due to potential leukemia involvement within the CNS, and then even blurred vision that may be correlated to ocular involvement of leukemia as well. And then lastly, chloromas are relatively specific to myeloid malignancies, which chloromas are extramedullary leukemia cells that form a tumorous mass, most frequently seen on the skin, bone, soft tissues, as well as lymph nodes. Although leukemia originates from the bone marrow, it's important to now that we've discussed the typical clinical presentation of a pediatric AML patient at diagnosis, let's spend some time discussing the typical diagnostic workup for one of these patients who presents with the symptoms that we described on the previous slides. At initial presentation, depending on the symptoms that a patient presents with and reports, a variety of blood tests will be sent off to really gain a better idea and some insight into what is actually going on within that patient's body. Based on the symptoms that we discussed earlier, a CBC with differential will be sent off in the initial set of labs, as well as a peripheral blood smear to gain some insight into how the bone marrow is functioning and likely showing us this irregularity in terms of the cells that it's producing, with the peripheral blood smear giving the laboratory specialist an opportunity to take a look at the blood sample under a microscope and really analyze those various cells. In addition to those two labs, additionally, a chemistry panel, hepatic function panel, as well as a coagulation analysis panel will be sent off based on the disease that the malignant disease that we think is likely occurring within the patient, and then to also help inform us of any type of tumor lysis syndrome that's occurring that we'll talk about in the next couple of slides, specifically looking for uric acid changes, potassium, calcium, as well as phosphorus changes. After initial labs result and through discussion with patients reporting their symptoms, the next step for a full diagnosis of pediatric AML is to really analyze and review the main site of disease, so the bone marrow. So a bone marrow biopsy and aspirate are typically required, of which then morphology, cytochemistry, immunophenotyping, as well as molecular and cytogenetic analyses are conducted. Per the World Health Organization classification, at least 20% of blasts, either in the bone marrow or peripheral blood, are required, or abnormal hepatopoiesis and specific cytogenetic abnormalities for this formal diagnosis. In addition to the bone marrow studies, a lumbar puncture to evaluate for CNS disease, plus or minus a CT or MRI, are typically recommended, given that the CNS is a sanctuary site for acute leukemias. So of your lumbar puncture CSF sample, cytology is run on that sample to analyze for potential leukemia in that area. And then lastly, a PET or CT is conducted or performed if extramedullary involvement is suspected. Now that we've discussed the bone marrow biopsies and some of the initial studies that are run on those samples, this slide is primarily here for your reference as a brief description of some of the immunomarkers that are evaluated for when initially working up a patient for AML. These immunophenotyping results ultimately are helpful in differentiating between myeloid malignancies and other types of leukemia. So on the left hand of your slide, listing out some of the myeloid lineage markers. And then on the right-hand side of the slide, listing off some of the various markers denoting the different types of AML, like we had talked about in the earlier classification systems. Once we have a confirmed diagnosis of AML, a variety of factors are all weighed in to determine the true risk stratification of a patient. These factors include cytogenetics, which we'll talk about on the next slide, molecular factors, as well as minimal residual disease after initial induction cycles. Ultimately, these factors will likely not be known at the time of diagnosis, so do not necessarily affect induction regimens, but ultimately will affect the post-induction therapy that we will talk about over the course of the next few slides. Similar to the immunophenotyping information that was described a few slides earlier, this cytogenetics slide provides a very brief overview of some of the various mutations and translocations that have been found to either be associated with a favorable or unfavorable response. Once we get the cytogenetic analysis back from our initial bone marrow sample, the bone marrow results or cytogenetic results will be reviewed for any potential favorable or unfavorable cytogenetic mutations or changes that then is taken into account for risk stratification. Regardless of the risk stratification of a patient, given that we likely won't have that information at initial diagnosis, the main backbone for pediatric AML therapy really relies on both anthracyclines and cytarabine in terms of the chemotherapy that they receive and respond to, hopefully. And then lastly, depending on the risk stratification, hematopoietic stem cell transplants, specifically allogenic transplants, also are a component of these patients' therapies. In terms of the various chemotherapy-containing cycles that these patients will generally receive, patients will receive remission induction, typically composed of 2 cycles, and then a post-remission induction phase of their therapy, which will discuss the different components of those 2 global phases. Overall, maintenance therapy hasn't found to be particularly effective within our pediatric AML patients, so there is no maintenance therapy associated with their chemo regimens. As I alluded to on previous slides, the first component of therapy for pediatric AML patients is this induction period, which typically consists of 1 to 2 cycles. The main goal of this induction period is to induce remission from a disease perspective. These remission induction cycles consist of primarily 3 to 4 agents. The initial agent, daunorubicin, being an anthracycline, which patients will receive 3 days of daunorubicin, typically on days 1, 3, and 5 of therapy. Cytarabine, which is a pyrimidine analog, which patients will receive cytarabine on 7 or 10 days of therapy, typically days 1 through 7 or 1 through 10. Of note, this is not high-dose cytarabine that we will discuss more when we talk about the chemotherapy agents. And then next, all patients will receive some type of CNS-targeted therapy, specifically an intrathecal chemotherapy dose administration. Further CNS therapy may be warranted depending on the amount or degree of leukemia within the CNS at diagnosis. And then lastly, depending on the FLT3 status or FLT3 status, patients may receive a multi-targeted kinase inhibitor that, again, we will talk about those specific agents when we go through all of the chemotherapy in depth. In an effort to continue to improve our overall survival for pediatric AML, There have been various attempts to modify the chemotherapy regimens and include various agents to try to improve overall survival. So with that being said, this study, conducted by Burnett and colleagues, was published in 2013 entitled The Optimization of Chemotherapy for Younger Patients with Acute Myeloid Leukemia, Results of Medical Research Council AML 15 trial. This specific study looked at the inclusion of etoposide within induction regimens and how that affected complete response as well as relapse-free survival, and then ultimately toxicities that patients experienced. So this study included adults and children with de novo or secondary AML between the years of May 2002 to January of 2009. The specific induction cycles included either ADE 10 plus 3 plus 5, which is a regimen of cytarabine on days 1 through 10, daunorubicin on days 1, 3, and 5, and then etoposide on days 1 through 5. They compared that induction regimen to the induction regimen DA 3 plus 10, which is cytarabine on days 1 through 10, and daunorubicin on days 1, 3, and 5. Ultimately looking at complete response rates and 5-year relapse-free survival. As you can see in the chart below, ultimately they were not able to detect, or they did not detect, any statistically significant difference between these two induction regimens with the inclusion of etoposide. If anything, they did notice or note an increase in grade 3 and grade 4 GI toxicity, which is suspected to be due to the inclusion of etoposide within that arm of the study. Ultimately, the authors concluded that the inclusion of etoposide within induction did not improve the rates of complete response or the durability of that response. And as such, the induction regimen described on the first slide has continued to be our mainstay of therapy. Another example of how various agents have been incorporated into frontline AML therapy to try to improve outcomes is bortezomib. So there was a study conducted by Athletic and colleagues that was published in 2020 entitled Bortezomib with Standard Chemotherapy for Children with AML Does Not Improve Treatment Outcomes. A report from the Children's Oncology Group was published. This study specifically looked at pediatric and adult AML that had been primary AML and previously untreated. Overall, they were globally looking to evaluate if bortezomib incorporated into each cycle of chemotherapy would improve outcomes. And this was initiated or evaluated after bortezomib initially showed some promising preliminary data about having some efficacy in AML. So the control arm was standard AML therapy, which consisted of 3 to 4 courses of chemo, depending on risk stratification, ultimately 2 cycles of induction, and then 1 to 2 cycles of intensification, compared with the experimental arm, which included the standard AML treatment, along with bortezomib on days 1, 4, and 8 of each chemo course. Ultimately, this study and these authors were unable to find any statistically significant improvement in either 3-year event-free survival or 3-year overall survival with the addition of bortezomib. Ultimately, they also reported that there was a statistically significant increase in the incidence of peripheral neuropathies with the addition of bortezomib. Ultimately, these authors concluded that bortezomib can be safely added to pediatric AML therapy. However, bortezomib itself did not significantly improve either event-free survival or overall survival and was associated with increased toxicity. With our standard of care AML induction regimens, our patients are at significantly increased risk of various toxicities and even mortality during induction as well. So specific toxicities that we monitor closely for and provide robust supportive care to prevent include tumor lysis syndrome, So these patients will continue to have tumor lysis syndrome panels drawn at least throughout their initial induction cycle to make sure that we're adequately providing IV hydration, allopurinol as indicated based on their disease status at baseline, and then to try to prevent any type of acute kidney injury or any type of downstream sequelae of this increase in uric acid, and then also increase in potassium levels, increase in phosphorus levels, and then ultimate reduction in calcium levels as well. Lending to that, one of the many sequelae of tumor lysis syndrome, cardiac abnormalities. So an example of that being arrhythmias, either based off of the chemotherapy that they're receiving or the TLS that they may be experiencing. Additionally, these chemo regimens ultimately result in significant pancytopenias and prolonged periods of myelosuppression, which put these patients at incredibly high risks of infection. Interestingly enough, within our AML patients receiving cytarabine, there have been reports of or correlations of increased Virden's group streptococcus infections. Interestingly enough, there have been reports during induction 1, an incidence rate of 3.7% up to an incidence rate of 10.6% during induction 2 of specifically Virden's group strep infections. So this is something that we are going to be monitoring our patients for any sign of infection, any fever, and having a low threshold to start broad spectrum antibiotics and ultimately culture them to make sure that we are treating them as appropriately and quickly as possible given their significantly reduced immune system. And then lastly, just to provide some global awareness, there was reported to be a 1.7% incidence of mortality during induction 1, for example. So we monitor these patients very closely to ensure that they are not only receiving the chemotherapy that they're indicated for to hopefully result in increases in overall survival and complete remission, but also to make sure that they are supported through this time as well. Following the initial remission induction cycle or cycles, patients then proceed onto the second phase of therapy, typically considered to be their post-remission therapy. This phase of therapy consists typically of 2 to 3 cycles, and ultimately the number of cycles and specific cycles that they receive all depend on their initial risk stratification. Most patients, if not all patients, will receive initially one post-remission therapy cycle that contains high-dose cytarabine as well as concomitant etoposide. And then patients will proceed on to either one or both of the following cycles. So a cycle containing high-dose cytarabine and concomitant mitoxantrone, and or high-dose cytarabine and asparaginase therapy, also referred to as Competency cytarabine, which we'll talk more about when we go through the chemotherapy in more detail. All of these various cycles then may be combined with a multi-targeted kinase inhibitor, all depending on the patient's baseline FUT3 or FLT3 mutation status. And then again, depending on patients' risk stratification, they may also proceed to an allogenic hematopoietic stem cell transplant, depending on what their initial risk stratification was. Now that we've spent some time discussing globally what our patients will receive in terms of chemotherapy cycles, let's start to talk about more of the specific information surrounding the various chemotherapy agents that these patients will receive. The first class of chemotherapy agents that we will be discussing today are the anthracyclines as well as anthracenediones. There are various anthracyclines on the market currently that are FDA approved for a variety of malignancy treatments. I listed them all generally on the slide for you, but today we are going to focus mostly on daunorubicin, given its role in remission induction phases of therapy, specifically for our pediatric AML patients. Anthracidiones are structurally similar compounds to anthracyclines, and we'll talk more about the differences in terms of the mechanism. But mitoxantrone we will also focus on today, given its role in the post-remission induction phase of therapy. In terms of understanding how these agents work, it's also important to understand the very subtle differences in the mechanisms of action between anthracyclines and anthracenediones. For anthracyclines, such as daunorubicin, there are three main components to its mechanism of action. It includes intercalation into DNA, inhibition of topoisomerase II, which then ultimately results in double-stranded DNA breaks, and then the generation of reactive oxygen species, which then move forward and continue to cleave DNA as well as cell membranes. Differing slightly, our anthracenediones have two main components to their mechanism of action, and that includes intercalation into DNA as well as the inhibition of topoisomerase II. It's important to note that these agents are only available via an intravenous route, and they can be administered in various ways in both short and prolonged continuous infusions, and we'll talk more about the components to that and considerations of that in the next few slides. There are a variety of adverse effects associated with this overall class of medications. We'll first discuss the more acute side effects that could be seen either during the infusion itself or within the initial 48 hours after administering a dose of an anthracycline or anthracenedione, and then we'll begin to discuss more of the later onset toxicities associated with these medications. First, discoloration of bodily secretions is frequently reported, and the color really depends on the anthracycline or anthracenedione that's being administered. Specifically, daunorubicin can result in red or orange tinged bodily secretions. Mitoxantrone can result in blue tinged bodily secretions, which is very important to counsel families on, especially if they're not expecting for that to potentially occur with their therapy. Secondly, there is either a low or a moderate emetogenic risk associated with these agents, but it's important to note that that risk may be increased depending on the agents that are concomitantly administered with anthracyclines or anthracenediones. So it's always important to confirm a patient's overall emetogenic risk and provide them with adequate control and prevention for that. And then lastly, in terms of acute side effects, these medications are considered to be vesicants, meaning that if extravasation does occur, both severe local tissue injury but also necrosis could result. Due to this, it is always recommended that these agents are administered through a central line if at all possible. Next, for some of our later onset toxicities, the first being cardiotoxicity, which is typically the most commonly remembered toxicity for this group of medications. It's important to note that this toxicity can be both early or late, although more frequently seen as later onset. Early cardiotoxicity typically presents through arrhythmias, either during the infusion or within a few hours after. Late onset cardiotoxicity can occur during the final months of therapy to months after. This late onset cardiotoxicity typically presents as reduced ejection fraction or congestive heart failure. As a result, patients will receive serial echoes to monitor their heart function during therapy and then following therapy as well. Due to this risk of cardiotoxicity, there is a recommended max cumulative dose for anthracyclines, and this all goes back to their overall risk of cardiotoxicity based on the dose that they're given. So with that being said, typically 450 to 550 milligram per meter square of doxorubicin equivalents is considered to be the maximum cumulative lifetime dose for anthracyclines or anthracenediones. As I stated, It's typically reported in doxorubicin equivalents. As a result, it's really important to keep track of what anthracyclines your patients receive in terms of what specific doses, but then also which agents so that they can be safely converted to doxorubicin equivalents so that we can keep track of their overall exposure and risk for cardiac toxicities in the future. Lastly, both mucositis as well as myelosuppression can occur in patients who receive anthracyclines, but typically that does not present until anywhere between 7 to 9 or 10 days after the administration of their initial anthracycline or anthracene-dione dose. Just to be thorough, there are both renal as well as hepatic components to this global group of medications, both metabolism as well as elimination. As a result, there are limited studies out there that have looked at the variable pharmacokinetics in patients with either renal dysfunction or hepatic dysfunction. As a result, it's always important to refer to tertiary references as well as primary literature if you have patients who present with either renal dysfunction or hepatic dysfunction. But globally, their doses should be reviewed for modifications that may be needed. Lastly, there are some interesting clinical pearls surrounding the cardiotoxicity risk with this group of medications. First of all, infusion duration has been found to play a role in the overall cardiotoxicity risk. Interestingly enough, investigators have found that by prolonging the infusion of an anthracycline or anthracene-dione, there's a reduced risk of cardiotoxicity, thought to be due to the reduced overall max concentrations that patients are exposed to, versus with shorter infusions or boluses, if you will, of this group of medications, causing an increased risk of cardiotoxicity. Interestingly enough, by prolonging the anthracycline or anthracene-dione infusion, there's thought to be an increased risk, or is found to be an increased risk in mucositis. So something to balance in terms of how we administer our anthracyclines and anthracene-diones. With the prolongation of the infusions of these medications resulting in increased mucositis risk, although reducing the cardiotoxicity risk, it was very fortunate that a relatively novel medication, dexrazoxane, was developed and studied. Dexrazoxane has been shown to reduce the cardiotoxicity risk of this class of medications, primarily through the mechanism of iron chelation, which then results in a reduction in generation of reactive oxygen species. So through this mechanism, it's been found to reduce the cardiotoxicity risk when administered immediately prior to an anthracycline or anthracene-dione dose. The exact dose of dexrazoxane that is recommended is purely dependent upon the specific anthracycline that's being used. So for daunorubicin, a recommended ratio of dexrazoxane to daunorubicin dosing of 10:1 is recommended. So if a dose of 50 milligrams per meter square of daunorubicin is being administered, a recommended dose of 500 milligram per meter square of dexrazoxane is recommended. Differing to a certain extent for mitoxantrone, a 40:1 ratio of dexrazoxane to mitoxantrone is recommended in any patient who is receiving that component of their AML therapy. The next chemotherapy agent that we will be discussing today is cytarabine. Cytarabine, again, is one of the key backbone chemotherapy agents that are associated with pediatric AML treatment. As the picture on the left-hand slide denotes, the main mechanism of action of cytarabine involves the internalization of cytarabine, conversion to cytarabine 5-triphosphate, and then acting as a false nucleotide that's incorporated into DNA. Through these activities or processes, cytarabine is able to inhibit DNA duplication and transcription, ultimately resulting in apoptosis. There are a variety of formulations of cytarabine, which include both intrathecal as well as intravenous. Intravenous infusions can also be administered via short infusions or long continuous infusions, so it's really important to make sure that you understand the exact administration method for a dose of cytarabine. And then generally speaking, there are different dose levels that are associated with different risks of certain toxicities that we'll talk more about in subsequent slides. Globally speaking, low-dose cytarabine is considered to be doses less than or equal to 200 milligram per meter square per dose. Intermediate dose cytarabine is considered to be greater than 200 milligram per meter square to less than 1 gram per meter square per dose. And then high dose cytarabine is classified as any dose that's equal to or greater than 1 gram per meter square per dose. There are a variety of toxicities or side effects associated with cytarabine. One of the reported syndromes that can occur with this medication's administration is appropriately titled cytarabine syndrome. This syndrome consists of the following symptoms, typically fever and malaise with one or more of the following: myalgia, arthralgia, maculopapular rashes, bone pain, and then some other symptoms that have been reported include confusion, tachycardia, as well as hypotension. The onset of this syndrome is typically within 6 to 12 hours after a dose of cytarabine is administered. And then there are a couple of different mechanisms that have been hypothesized within the literature, but ultimately some recent studies have found that there's an increase in pro-inflammatory cytokines within patients who experience this syndrome, specifically tumor necrosis factor alpha, interleukin-6, and interferon gamma, which may play a role in the downstream sequelae and symptoms that patients experience. As a result, treatment with corticosteroids has been found to be efficacious within the literature, and there is also literature out there for the use of corticosteroid to prevent a secondary prevention for this syndrome in patients who require additional cytarabine doses. I listed the remaining more frequently encountered or severe side effects to cytarabine that have been reported on this slide. The first being ocular toxicity, so both corneal toxicity as well as hemorrhagic conjunctivitis have been reported. There's a higher risk of these toxicities with high-dose cytarabine. As a result, any patient receiving high-dose cytarabine is recommended to receive either corticosteroid eye drops or artificial tear eye drops, scheduled 4 times a day, starting immediately prior to the dose of cytarabine until at least 24 hours after the final dose of cytarabine. Again, only in patients receiving high-dose cytarabine because they're at a higher risk. Secondly, any patient receiving cytarabine is at a risk of nausea and vomiting. It is dose dependent. There are higher risks of emetogenicity with higher doses of cytarabine, so it's always important to review your patient's antiemetic regimen to ensure that they have appropriate prophylaxis on board depending on their regimen. There is neurotoxicity associated with cytarabine use, again specifically high-dose cytarabine, which is thought to be due to higher concentrations and an increased risk given additional drug penetration to the CNS. This typically presents as acute cerebellar toxicity, so dysphagia, ataxia, unsteady gait. It can also present with an onset of about 3 to 4 days after a dose of either intrathecal cytarabine or high-dose cytarabine as well. Next, gastrointestinal toxicity, mucositis, diarrhea are all potential side effects of cytarabine. Myelosuppression is quite significant depending on the dose that's administered of cytarabine and the duration. Pulmonary toxicity, and then lastly, the risk of infections, which can in part be correlated back to the myelosuppression risk, both the severity of myelosuppression as well as the duration of myelosuppression. And then interestingly, patients receiving cytarabine have been shown to be at a higher risk of Virden's group streptococcus infections. There are both hepatic metabolism as well as renal elimination components to cytarabine's overall pharmacokinetics. So really important to note that as the dose of cytarabine you're administering gets larger and approaches high dose cytarabine level dosing, there is more of a reliance on your patient's renal function for full clearance of drug. So there may be dose modifications needed with significant renal impairment, especially in patients who are receiving high-dose cytarabine. The manufacturer recommends avoiding high-dose cytarabine in patients with severe renal dysfunction for that reason. The next drug that we are going to discuss today that's a component of frontline AML therapy is etoposide. Etoposide functions primarily as an inhibitor of topoisomerase II, so somewhat of a similar global mechanism as our anthracyclines, at least that component. Etoposide is primarily available as an IV product, although some malignancies will include oral administration of etoposide. For our purposes today and focusing on pediatric AML therapy, they will receive intravenous infusions of etoposide, typically over 1 to 2 hours, depending on the dose that's administered, which we will discuss next. There are a variety of side effects associated with etoposide administration, which can be further separated or classified as acute side effects or later onset or chronic side effects. For the acute side effects, the two main side effects that are reported with etoposide use include infusion reactions or hypersensitivity reactions. As I alluded to previously, the rate at which etoposide doses should be administered is recommended to not exceed a rate of 100 milligram per meter square, and that's all due to the risk of infusion reactions. Similarly, there's also a potential risk for infusion reactions due in part to the preservatives or inactive components to the etoposide drug formulation as well, specifically polysorbate 80 and or benzyl alcohol. As a result, if patients experience severe infusion reactions or hypersensitivity reactions, it's important to note that could be due to the drug itself or to the preservatives, which we'll talk more when we get to the clinical pearl slide. Lastly, some of the more chronic or later onset side effects include myelosuppression, so significant in terms of severity as well as duration, and then the risk of secondary malignancies. Etoposide itself is hepatically metabolized as well as renally eliminated. So in any patients with severe renal or hepatic impairment, it is incredibly important to assess the potential need for drug-drug interactions. Lastly, to discuss some clinical pearls for etoposide, if we go back to the infusion reactions that may occur with the drugs administration, there are a couple of different modifications that can be made to etoposide therapy to allow for hopeful patient tolerance of the infusions. One option is to extend the infusion duration and to reduce the infusion rate. Additionally, there have been some reports of utilizing pre-medication, so considering Benadryl pre-medication. And then lastly, there is an alternative etoposide product, etoposide phosphate, that does not include the preservatives that are in the etoposide formulation. Etoposide phosphate is a more water-soluble prodrug that doesn't require those preservatives. And then for the last clinical pearl related to etoposide use, etoposide is hepatically metabolized, as I spoke about before, and it is a major substrate of CYP3A4, so it's incredibly important to really monitor for potential drug-drug interactions, especially when you're considering certain infection prophylaxis that these patients will receive. Specifically, examples include voriconazole or posaconazole. The next component to pediatric AML therapy that we will discuss today is asparaginase therapy. We'll quickly discuss the global mechanism of the drug and then in subsequent slides talk about how that really plays a role in pediatric AML treatment. So big picture and generally speaking, asparaginase therapy, as you can probably tell by the suffix of the name, is an enzyme that catalyzes the conversion of asparagine to aspartate as well as glutamine to glutamate that's thought to then result in overall apoptosis of leukemia cells. And we'll kind of talk about how that translates to AML therapy. There are two main formulations of this medication, and that includes both intramuscular injections as well as the intravenous infusion route. The most significant or the most frequently reported adverse effects associated with asparaginase therapy are listed on this slide for your reference. The first being hypersensitivity reactions given the type of product, and we'll talk a little bit about that on subsequent slides. And then both hyper and hypoglycemia, as well as a variety of coagulopathies due to dysregulation in protein synthesis and functionality, hepatotoxicity, and then pancreatitis. In terms of clinical pearls associated with asparaginase therapy, I would be remiss not to touch upon the method in which asparaginase therapy is provided to frontline pediatric AML patients. As we discussed earlier on in the presentation regarding the cycles that patients receive, pediatric AML patients will only receive asparaginase therapy during one specific cycle of their regimen if they receive it at all, and that's in combination with high-dose cytarabine. Specifically, patients will receive 4 doses of high-dose cytarabine every 12 hours in a row, with then a dose of short-acting asparaginase therapy 6 hours after the start of the final cytarabine dose, which is very specific and particular. That is because there has been in vitro data to support a synergy between high-dose cytarabine and asparaginase when administered in this method, which was studied and ultimately published by Competency and colleagues, hence the name of Competency style asparaginase and cytarabine therapy. With that being said, as I've just alluded to, there are various products, so I wanted to make sure I touched upon that generally speaking, but then focusing on what our patients, being pediatric AML patients, will receive. And as you may already know, there are short-acting as well as long-acting asparaginase therapy products available in the market, long-acting being the pegylated products, the short-acting being the non-pegylated products. So specifically, asparaginase erwinia as well as asparaginase erwinia recombinant, which has been very recently FDA approved. The final group of medications that we will be discussing today that are a component of frontline pediatric AML therapy are these multi-targeted kinase inhibitors. If you recall from earlier on in the presentation, this group of medications is utilized in patients who are diagnosed with AML who also have an activating FUT3 mutation. You may be wondering, what is FUT3? FUT3, the full name is FMS like tyrosine kinase 3, which is a cytokine receptor. Ultimately, when FUT3 is activated, there's an increase in multiple intracellular signaling, which then results downstream into hematopoietic cell survival and proliferation, as well as a reduction in apoptosis. Patients who present with this type of mutation ultimately have this as one of the drivers of their disease. As a result, patients then are given these inhibitors to try to target that mutation. I included on the slide in the red box the 3 most common FUT3 inhibitors that you are likely to see in pediatric clinical practice, specifically midostaurin, sorafenib, and gilteritinib. It's important to note that midostaurin and sorafenib are both first-generation FUT3 inhibitors versus gilteritinib, which is a second-generation FUT3 inhibitor. First-generation FUT3 inhibitors display relatively limited selectivity for the FUT3 receptor, meaning they have various off-target effects. In comparison, second-generation FUT3 inhibitors are thought to have greater selectivity for the FUT3 receptor, and then ultimately less toxicities due to their less off-target effects. I would be remiss to not also describe that there are relatively limited dose formulations for these agents, specifically only oral dose formulations. Sorafenib and gilteritinib are available as an oral tablet, whereas midostaurin is available only as an oral capsule. We will now begin to discuss the differing adverse effect profiles for these various FUT3 inhibitors. We'll first start with midostaurin. I've listed the most common and significant adverse effects on the slide for your reference, but interestingly to note, both bone marrow suppression as well as an increased risk of cardiotoxicity are thought to be due to off-target effects of midostaurin. Again, different from gilteritinib that we'll talk about in a little bit. QTc prolongation has been reported in up to 12% of patients, depending on the patient population, and then there's been an incidence of hyperglycemia in up to 20% of patients, again, depending on the population you're looking at. Lastly, for dosing considerations, there is not thought to be a significant effect on midostaurin pharmacokinetics in the setting of renal impairment, but there is very limited literature supporting any necessary modifications. With that being said, there are significant hepatic metabolism components to midostaurin's pharmacokinetics, so it's really important to consider the need of dose modifications in specific patient populations. Lastly, midostaurin is a major substrate of CYP3A4, so it's really important to always review a patient's profile for any potential drug-drug interactions. Similarly, for sorafenib, I listed the most commonly reported or significant adverse effects on the left hand of the slide for your reference. Again, important to note the increase in adverse effects, again, likely due to off-target effects. Specifically due to VEGF inhibition, sorafenib has been associated with hypertension development. Just going through the list in its entirety, there's also a risk of rash, hand-foot syndrome, QTc prolongation, hepatotoxicity, and then also bone marrow suppression. In terms of dosing considerations, there may be modifications necessary in both renal and hepatic impairment, so be sure to always fully assess your patient's end organ function. And then lastly, sorafenib is also a major CYP3A4 substrate, so it's really important to always consider any potential drug-drug interactions that could affect sorafenib pharmacokinetics. The last FLT3 inhibitor that we will discuss today is gilteritinib, again a second-generation FLT3 inhibitor. I listed the most frequently reported or significant adverse effects on the left hand of the slide. The most commonly reported side effect primarily being bone marrow suppression, but then also diarrhea, hepatotoxicity, and then there have been some reports of posterior reversible encephalopathy syndrome, or PRES. If your patient ever presents any significant neurologic symptoms, it's really important to perform the appropriate imaging and that be escalated to ensure that appropriate supportive care is provided if needed. Lastly, for dosing considerations, renal impairment is not likely to play a significant role in the pharmacokinetics of gilteritinib, but hepatic dose modifications may be necessary depending on the severity of hepatic dysfunction. And then lastly, gilteritinib is also a major substrate for CYP3A4, so a drug-drug interaction review is really important. Now we will begin discussing some novel as well as targeted agents that have been slowly incorporated into frontline AML therapy, as well as some agents that are currently being utilized for the treatment of relapsed or refractory AML. The first medication that we will discuss is gemtuzumab ozogamicin, which is a humanized CD33 antibody drug conjugate. This medication is made up of an IgG4 kappa antibody that targets CD33 linked to a cytotoxic calicheamicin derivative. Ultimately, this antibody binds to CD33 on AML cells, is internalized, and then the calicheamicin component is released, which then results in DNA double-strand breaks leading to cell apoptosis and cell death. There are quite a few clinical pearls associated with this medication. As this medication is administered as an IV infusion and as a monoclonal antibody, infusion reactions have been noted with this agent, and universal pre-medication is recommended, specifically triple pre-medication with acetaminophen, a histamine 1 receptor antagonist, such as Benadryl, and then as well as a corticosteroid, such as methylpred. Additionally, hepatotoxicity, including the risk of sinusoidal obstruction syndrome, is a significant risk associated with this agent. As a result, it is recommended to consider ursidiol prophylaxis as a method to try to decrease the risk of more long-term hepatotoxicity, especially in transplant patient populations or patients expecting to proceed to transplant, which would be a majority of our AML patients who are receiving this agent. Lastly, it is also associated with QTc prolongation. There was a study published in 2014 by Gamiz and colleagues entitled Gemtuzumab Ozigomycin in Children and Adolescents with De Novo AML Improves Event-Free Survival by Reducing Relapse Risk. Ultimately, this Children's Oncology Group study looked at evaluating children, adolescents, and young adults with newly diagnosed AML and whether the addition of gemtuzumab ozigomycin, or GO, improved overall outcomes. Ultimately, they found a statistically significant improvement in 3-year event-free survival with the addition of gemtuzumab, as well as a significant increase in disease-free survival within the gemtuzumab group. These authors ultimately concluded that gemtuzumab ozigomycin added to chemotherapy improved event-free survival through a reduction of relapse risk for children and adolescents with AML. The next agent that we will discuss today is liposomal daunorubicin cytarabine, also referred to as CPX351 in some initial pediatric studies, which some of you may be used to. I listed a picture on this slide that really denotes and captures the liposomal encapsulated formulation of this agent, but we will discuss more about the dosing as well as some clinical pearls on the next slide. Some clinical pearls associated with this medication. It's important to note that it is manufactured via a synergistic ratio of daunorubicin to cytarabine, specifically a 1:5 ratio. It has increased accumulation into the bone marrow and then selectively taken up to a greater extent by our leukemia cells based on initial animal models, which is why it presents as a optimistic addition to pediatric AML therapy as well as adult therapy. Lastly, it's hypothesized to also have less cardiotoxicity based on the pharmacokinetics, although we'll continue to get more information and validate that finding. Lastly, it's dosed typically based on milligrams of the daunorubicin component, but it's always important to confirm before you verify a specific order or make a specific dose. The final agent that we will be discussing today is venetoclax. And venetoclax is a BCL2 inhibitor. BCL2 stands for B-cell lymphoma 2, which is an anti-apoptotic protein, which is thought to promote tumorigenesis as well as chemotherapy resistance. So through inhibition of this process, there's thought to be a restoration in apoptosis. Important to note that BCL2 has been shown to be overly expressed in certain AML populations or mutations, although it's quite heterogeneous. Overall, there is thought to be some degree of apoptotic dysregulation, making this drug an optimistic agent to incorporate into AML therapy. Some clinical pearls for venetoclax is that it's only available commercially as oral tablets, specifically 10 milligram, 50 milligram, and 100 milligram tablets. So we have to be a bit creative in terms of dosing regimens for our pediatric patients. Additionally, it's a major substrate of CYP3A4, so there are numerous drug-drug interactions that can occur in patients who commonly receive our azole therapies, as well as other CYP3A4 inhibitors. And then lastly, in most package labeling, there will be a ramp-up initiation within the initial few days of therapy to avoid tumor lysis syndrome that's been seen primarily in adult patient populations. The last study that we are going to discuss today was published by Carroll and colleagues in 2020, entitled Venetoclax in combination with cytarabine with or without idarubicin in children with relapsed or refractory AML, a phase 1 dose escalation study. This study specifically evaluated pediatric and young adults with relapsed or refractory AML. You'll see within the intervention portion of this chart a steady increase in venetoclax dosing from 240 milligram per metered square up to 360 milligram per metered square, and then the incorporation of intermediate dose cytarabine escalated to high dose cytarabine, and then finally for dose level 4, the addition of idarubicin. This slide displays the results of this study, generally speaking. You see an increase in overall complete response rates as the interventions progressed from dose level 1 up to dose level 4 with the addition of high-dose Ara-C as well as idarubicin. Although no dose-limiting toxicities were reported in dose levels 2A, 2B, 3, or 4. As a result, the authors concluded that this regimen, this dose level 4 regimen, should be evaluated in a phase 2 study, specifically venetoclax dosed at 360 milligram per metered square once daily, cytarabine 1000 milligram per metered square per dose every 12 hours for 4 days or 8 doses, and then idarubicin 12 milligram per metered square for 1 dose. But ultimately, further studies are warranted to truly test this chemotherapy combination in newly diagnosed or frontline AML patients. Now that we've discussed frontline pediatric AML therapy as well as some novel agents that are slowly being incorporated into frontline therapy or relapse refractory regimens, let's quickly discuss some general pediatric chemotherapy considerations that globally have a huge impact on our pediatric AML patients. First of all, a friendly tidbit that dosing units do vary between different pediatric populations as well as different protocols, so it's really important, regardless of the regimen that you're using, to always double check the specific units that are being used to dose your chemotherapy agents. Specifically, both weight-based, so milligram per kilo, as well as BSA-based milligram per metered square dosing are incorporated. Second, you'll notice that there are some oral agents that do possess quite limited dosage formulations, so it's really important that we play a valuable role in being creative and helping to ensure that our patients are able to receive the necessary treatment options. Lastly, our patients, regardless of the stage of therapy, are at an increased risk of infections throughout their entire therapy as well as relapse or refractory regimens. As a result, it's really important to make sure that your patients receive the necessary infection prophylaxis, which include at times both bacterial and fungal prophylaxis, as well as PJP or pneumocystis jirovecii prophylaxis. To summarize the global concepts that we reviewed today, frontline pediatric AML therapy involves intense myelosuppressive chemotherapy regimens, which ultimately results in prolonged periods of neutropenia and an increased risk of infection. Additional targeted therapies may be incorporated into frontline therapy depending on a patient's FLT3 status. Allogenic stem cell transplantation is utilized for patients who are at a higher risk of relapse. And then lastly, research is continuing to be conducted to evaluate opportunities to reduce risks of relapse and overall toxicities in our patients. These next 2 slides contain all of the citations from this presentation. Lastly, we will quickly go through some audience participation questions. First, all of the following are conditions or diseases that have been associated with AML except A. Fanconi anemia, B. alkylating agents, C. sickle cell anemia, or D. topoisomerase II inhibitors. If you recall from our initial slide on the various etiologies of pediatric AML, sickle cell anemia has not yet been correlated with AML and diagnosis. For audience participation question number 2, what are the chemotherapy agents that make up the remission induction cycles? A. High-dose cytarabine and CNS-directed therapy. B. Cytarabine, daunorubicin, CNS-directed therapy, plus or minus multi-targeted kinase inhibitor therapy. C. Etoposide and high-dose cytarabine and daunorubicin. And then D, high-dose cytarabine, asparaginase therapy, plus or minus multi-targeted kinase inhibitor therapy. And the correct answer is B. So cytarabine, daunorubicin, CNS-directed therapy, and then multi-targeted kinase inhibitor therapy if they have a FLT3 mutation. Audience participation question number 3. High-dose cytarabine requires what specific supportive care agent? A, Mesna, B, corticosteroid eye drops, C, systemic corticosteroids, and then D, hyperhydration, intravenous fluids. And the correct answer is B, corticosteroid eye drops, and that goes back to the risk of ocular toxicity associated with high-dose cytarabine. Next, audience participation question number 4. Which of the following chemotherapy agents are associated with significant infusion reactions and require universal premedication? A, cytarabine, B, etoposide, C, gemtuzumab oligomycin, or D, liposomal cytarabine daunorubicin. Answer is C, gemtuzumab oligomycin. And then lastly, for audience participation question number 5, which of the following components of therapy could a frontline patient with AML receive? A, induction plus post-remission therapy plus maintenance therapy. B, just 2 cycles of induction. C, induction therapy, post-remission therapy plus autologous hematopoietic stem cell transplant. Or D, induction plus post-remission therapy plus allogenic hematopoietic stem cell transplant. And the correct answer is D. So induction therapy plus post-remission therapy and allogeneic hematopoietic stem cell transplant. Again, this is one of the possible regimens depending on the risk stratification of the patient, but ultimately autologous hematopoietic stem cell transplants are not recommended. We typically would never give just 2 cycles of induction, as we just spoke about earlier in the presentation, and then we had discussed earlier in the presentation how maintenance therapy is not found to be effective in improving our overall survival. Thank you all for attending this presentation today, and please feel free to contact me if there are any questions that are lingering or if there's any additional information that I can provide.